Those are my disclosures, really none for this particular presentation, and that is what I'll go through. Professor Polter has done a good job and made me almost redundant because many of the things I'm going to say, he has said it. But they say that in education, repetition is good, so some of these things will be repeated. So the first slide is about the burden of hypertension in terms of how much death it causes. And Professor Polter has said that about 11 million deaths estimated in 2019. That is almost 1 in 5 deaths in the world is attributable to hypertension, being 19.2%. The next is this, which he showed the big figure on the left. What I want to focus on is the one on the right bottom, which is Africa. The red bit, like most men, I'm colorblind, so if I mention the color wrongly, please pardon me, is the people who have got undiagnosed hypertension. If you look at the global figure, that number is more or less flat. If you look at the African data, that is going up. So that's an extra challenge. The next bit are people who are diagnosed. You look at the rest of the world, it seems to be going up. In Africa, it is constant at best. The light green color is those who are on treatment. It's just a sliver in the African context. And the top, which is the dark green color, is those who are controlled. So we are doing very poorly in terms of control. This is sort of Africa-specific data. On the left is a meta-analysis of studies in Africa that was done, published about 8 years ago now. And again, the blue bar is people who have hypertension. The next one are people who have been diagnosed, who are aware, and they are only 17%. And it goes down to the yellow or orange or whatever it is, which is only 7% control. Now, if on the right is Kenyan data from a survey we did way back, published in 2018, I think we did it in 2015. So awareness is only 15%. So 85% of the population who have hypertension don't know it. Only about a quarter of those are on treatment. So a quarter of 15 is something like 4-point-something%. And the good news there is that those who are on treatment, the rates of control were pretty good. Now, this is a figure that I've borrowed from a publication that Neil Polter was part of. This is the original World Heart Federation roadmap on the control of hypertension. And it looks at all the parameters, all the steps that we need to act on to control blood pressure. So people who have got high blood pressure need to know that they have high blood pressure. We need to link them to treatment, treat them to control, and make sure that they adhere. My only issue with this is that it starts at people who already have high blood pressure. And as Neil has rightly said, we should actually start higher with the primordial prevention of hypertension. Now, so what are some of the specific situations that explain this very poor control? This is Kenyan data from the survey that I told you about. And if you look at the overall figure of all adults in Kenya, 71% have never had a blood pressure measured in their lifetime. 71 for men. Women do better at about 40%. If you look at the global figure, more than half of Kenyan adults have never had a blood pressure measurement. This is a slide I borrowed from my colleague Anastasia, who is talking after me. So they looked at a HIV population in Cameroon where he comes from. And this is a population that interacts with the healthcare system very regularly. And even in that population, the majority of people who had high blood pressure didn't know. And yet this is one of the simplest things to do in the world, putting a cuff on somebody's upper arm and inflating the cuff. This is a study that we did in Kenya to look at primary healthcare workers' knowledge about various things in hypertension. What are the risk factors for hypertension? What are the consequences of hypertension? And very simply, what constitutes hypertension? what is the threshold of the blood pressure that constitutes hypertension. And in the interest of time, I won't go into too much detail about it, but you can see, for example, less than 30% know that alcohol is a risk factor for hypertension, or that hypertension causes heart failure or kidney disease. This is a study we did in our National Referral Hospital, Kenyatta National Hospital, looking at adherence, control, and the relationship between the two. And even in a tertiary center, just about half of the patients were well controlled. Adherence was very poor at less than a third, and as expected, there was clearly an association between adherence and control. So this is an update of the World Heart Federation roadmap on hypertension that was published in 2021, and it looked at these factors that prevent the control of hypertension from a demand side, and you can read that, and from a supply side. So it sort of summarizes most of what I've said and what Neil has said. This is from a publication that one of our chairs was involved in, Professor Damasceno. It was a Lancet publication on hypertension. And it looks at control of hypertension across the whole lifespan. And it has got 3 important points here. That if you are dealing with a very young population, the first important thing is to prevent the development of hypertension. So that's what we have talked about, primordial prevention. If you look at an older population that have unfortunately developed high blood pressure, then the next thing is to treat them to prevent the development of hypertension-mediated organ damage. And if you escape that, then of course, prevent incident cardiovascular disease, strokes, heart failure, ischemic heart disease. And the details on the side detail what you can do in each of those states. This is the PASCA adaptation of the initial World Heart Federation roadmap on hypertension. Our chair then was Professor Zudi, who is talking after me, and we mentioned various things that need to go into a program at a community level, at a national level, to ensure population control of hypertension. Kenya has been a part of the MMM program that Professor Polter talked about. And this data is from the first 2 years of MMM, 2017, 2018, and 2019. And if you look at the last column here, we've got better figures of control than I showed from the National Cardiovascular NCD Risk Factor Survey. Now, this could be spurious because this is not representative, but we think that this is a validation of the various efforts that have been done nationally and that we are getting improved control rates. We are in the process of doing the national survey currently, and it is our hope that this will be validated. Now, in the last ISH hypertension guidelines, this was defined as what is an ideal drug. And one of those is that there should be evidence of use of the medication in the population in which it is being applied. And this is one of the things that we did. Again, almost everybody who is speaking here was involved in this program, the so-called Creole study, where we looked at what is the optimal combination therapy for treating hypertension in Black populations. So instead of giving my own take-home messages, I took this summary from the WHF roadmap of 2021 because I think it summarizes it very well. So population-wide prevention and control, opportunistic screening like MMM, encourage out-of-office blood pressure measurements, pharmacies, markets, churches, mosques, everything, strengthening of primary health care, task sharing, which has been mentioned, people-delivered care, strengthen patient and carer education, facilitate adherence. Yes, I think I've run out of my time. So the next thing was appropriate treatment, and what I want to stress there is single pill combination and the use of technology. And thank you very much for your attention.